This is a production from the Center to Accelerate Population Research in Alzheimer's. This work was supported by the National Institute on Aging of the National Institutes of Health and by the Institute for Healthcare Policy and Innovation at the University of Michigan. The content is solely the responsibility of the presenter and does not necessarily represent the official views of the National Institutes of Health or the University of Michigan.
Hi, this is Ken Langa from the Center to Accelerate Population Research in Alzheimer's, or CAPRA, at the University of Michigan, and I'll be providing a brief introduction to studying dementia in the health and retirement study. Just wanted to acknowledge our funders. The National Institute on Aging funds both the CAPRA Center and the Health and Retirement Study, and the Social Security Administration also provides additional funding for the HRS. What I'll do in this brief seminar is provide an introduction to the HRS, focus in a bit on the cognition measures in the HRS, then describe two of the sub-studies on dementia that we've done as part of the Health and Retirement Study, the Aging Demographics and Memory Study, or ADAMS, and the Harmonized Cognitive Assessment Protocol, or HCAP, and then just briefly show a few examples of research on dementia that have been done with the HRS. So to start, the HRS essentials. The HRS was created in 1990 by an act of Congress to provide public data for the study of health and retirement. As the baby boomers were getting close to the retirement age, it was felt that much more data were needed to understand the implications of aging into retirement for the baby boomers. It's the first longitudinal study of older people to include detailed economic and health information in the same survey. It's a large project. There are currently 16 co-investigators from various disciplines. The principal investigator of the HRS is David Weir at the University of Michigan. It's the largest and most comprehensive, nationally representative, multidisciplinary panel study of Americans over the age of 50, and again, supported by the NIA and SSA. Essential information about the HRS: it's nationally representative of the population over age 50. Follows individuals and their spouses from across the United States, the 48 contiguous United States, from the time of their entry into the survey until death. It introduces a new 6-year birth cohort of participants every 6 years. And at any given wave, there are about 20,000 respondents that are interviewed, and over 43,000 respondents have ever been interviewed since the start of the study in 1992. Just to show you, give you a little bit better view of what the HRS design looks like. Again, the study started in 1992 with a sample of individuals from across the United States who were 51 to 61 years old, sort of known as the original HRS cohort. The next year, there was an older cohort added, initially called the AHEAD cohort, starting in 1993. But then in 1998, these two cohorts were sort of combined and the age gaps filled in. So starting in 1998, the HRS has been representative of the 51 and older population in the United States. And then every 6 years, as I mentioned, there is a new 51 to 56-year-old cohort entered to backfill the sample and keep it age representative, and that was done in 2004, 2010, 2016. The late baby boomers were added, and in 2022, the first individuals from Generation X or Gen X will be added to the HRS. The HRS also has international partners around the world, studies that have been patterned on the HRS in both sampling strategies as well as questionnaire, with the goal of developing comparable data in high and low income countries around the world. You can see this map here where HRS partner studies are currently being performed. There's more than 30 studies around the world that have been collecting data patterned on the HRS. And all of that information, I'll provide some websites later. The Gateway to Global Aging website, run at the University of Southern California, gathers all of this international data together and provides it to users. Here is just a brief outline of the different domains of data collected in the health and retirement study. Most relevant probably for today are direct cognitive testing, as I mentioned, which I'll provide more detail on. Lots of information on family and family caregiving, obviously an important issue with cognitive decline and dementia. Lots of economic information about employment and assets and income. And then beginning in 2006, additional biological data began to be collected, first as dried blood spots, and then in 2016, a full venous blood sample through phlebotomy that provides biomarkers. There's also genetic information, and also importantly, links to administrative data, including Medicare data, National Death Index data, Veterans Affairs data, and Social Security Administration data. So to focus in again on our main area of interest for this brief seminar, the cognitive measures in the HRS. At every wave, every core wave, every 2 years, we collect or we administer a number of cognition tests, either in person or over the phone. And you can see them here: an immediate and delayed free recall test, list learning of 10 nouns, serial sevens, counting backwards, vocabulary, and a number of mental status measures, including orientation and asking the president and vice president. So in many ways, sort of patterned on the mini mental state exam, or also what's known as the telephone interview for cognitive status, sort of collecting basic cognitive information across different cognitive domains. And obviously, there's much more information about these measures and how they're administered at the HRS website, which I'll provide later. Additional cognition measures, we have self-rated memory. We ask people to rate their memory as excellent, very good, good for fair, or poor. Change in memory. Also ask about self-report of diagnoses. Has a doctor ever told you that you have memory problems or Alzheimer's disease? Added some additional measures in starting in about 2010, numeracy measures. You can see those questions there, asking or trying to get at how well people can handle numbers and percentages, do some number series problems. Also added verbal fluency test, the animal naming test, where people are asked to name as many animals as they can in a 1 minute time period, and then also some verbal analogies. Just a few methodological issues to consider, and obviously as people dig into the data, these will be issues relevant issues that they'll want to think about some more. There's always a question of practice effects for cognitive testing that's done multiple times. Do people get more comfortable taking the test and their scores may improve in the second administration of the test? We work hard to try to standardize test administration with significant training for our interviewers and how to set up the test environment. Obviously, interesting methodological questions about telephone versus face-to-face interviews and different testing environments. And then obviously the important issue of incomplete data. As people become more impaired in cognition, they may not be able to answer some of our questions, and we work hard to then recruit proxies who can provide information on cognitive status and functional status for people that aren't able to answer or participate in the surveys anymore. And here's some of the proxy questions that we ask when we do recruit a proxy to provide information, asking them to rate the respondent's memory. We administer the standardized JORM IQ code, which is a 16-item version, which asks the be proxies to talk about or describe changes in various cognitive and functional activities over the last 2 years prior to or since the prior wave, and then also ask about some behavioral problems that can arise due to cognitive decline and dementia. All right, turning to the intensive sub-studies of cognition and dementia that we've done as part of the HRS. In the early 2000s, we administered the Aging Demographics and Memory, or ADAMS study. And again, the initial field period was from between 2001 and 2005, and then we did follow-ups through 2010. A total of 856 subjects were evaluated in their homes with an intensive 3 to 4 hour neuropsychological assessment, neurologic exam, informant interview, and genetic testing. And then all of that information was reviewed by a consensus panel of experts, internists, neuropsychologists, neurologists, and a consensus diagnosis of cognitive impairment without dementia, or CIND, or dementia was made, as well as a differential diagnosis for the cause of dementia. A number of different methods have been developed to use the information both from the core HRS survey and from ADAMS to try to categorize all of the respondents in the HRS with dementia or not. Again, a number of methods, including equipercentile equating, where you define cut points on the HRS cognitive and other measures in order to create a dementia prevalence that is the same as the gold standard ADAMS estimate. And then there's been a number of regression-based algorithms that have been developed. Again, these are described more at the Health and Retirement Study website. You see the citations there to learn more about these kinds of issues. Most of the research done on these algorithms show that accuracy is quite good when using the cognitive information, both from the core surveys and ADAMS. You can see accuracy in the 90% or better range. I would recommend having trouble advancing my slides here again. Whoop. There we are. Again, I would recommend looking at some of the work, especially by Giannattasio and colleagues. Melinda Power have really dug into these algorithms, and you can see one of the published papers here from Epidemiology in 2019. More recently, in 2016, a second intensive study of dementia in the HRS was implemented, the Harmonized Cognitive Assessment Protocol. And what that entails is a one hour of cognitive testing for the respondent and about 20 minutes of questions for the informant. So significantly more information than the core survey, but less information than ADAMS. And we have included about 3,500 HRS respondents in the 2016 wave of HCAP. Those are the 65 plus sample. And again, the battery of cognitive tests, which is available at more information, obviously, again, at the HRS website, was developed in collaboration with our international partners. The main goal of HCAP was to develop a protocol that could be compared in valid ways across countries, and that has been a focus. And again, obviously, this additional information provides much better characterization of cognitive function in the HRS subsample embedded in the ongoing HRS. Okay, just to finish up, just to give a few examples of some of the research opportunities in dementia. Obviously, the economic impact of dementia is of increasing interest as the number of people with dementia has been increasing in the United States and around the world. This was a study led by Michael Hurd at the RAND Corporation, estimating the full economic impact of dementia in the United States using all of the information from ADAMS and the core HRS. Some of the punchlines of this study were that The average cost per case or additional cost per case was about $50,000 in 2010 dollars, and much of the economic impact of dementia is due to informal care, the care provided by families, long-term care in nursing homes, and out-of-pocket spending. We've also done some work to try to understand trends in dementia prevalence in the United States. We found between 2000 and 2012 a decline in the prevalence of dementia among those who are 65 plus. This optimistic trend has been found in other studies in the United States, as well as in other high-income countries around the world. It's thought that perhaps rising levels of education and perhaps better control of cardiovascular risk factors may be the reasons for this declining prevalence. Colleague here at the University of Michigan, Jack Awashina, has done some interesting work with the linked Medicare data to try to understand how severe illness, in this case severe sepsis, affects long-term cognitive function and physical function. And he found that sepsis was independently associated with a substantial and persistent new cognitive impairment and functional disability among survivors. And the magnitude of these new deficits was large, likely resulting in a pivotal downturn in patients' ability to live independently. So again, a nice example of the value of linking both detailed Medicare records with the long-term cognitive and other functional information in the HRS survey. So to conclude, population-based studies of dementia we think are especially important now given aging of populations around the world. The HRS and ADAMS and HCAP have been designed to leverage the existing HRS family of nationally representative studies. Our goal is to collect multidisciplinary data to compare and track dementia burden on patients, families, and health systems in countries around the world. All the data are publicly available at the HRS and Gateway to Global Aging websites. And here is a bit of a busy slide with all of those various websites, the HRS and HCAP information there at the HRS website, and the Gateway to Global Aging data there at the University of Southern California. Thanks very much.
Make sure to check out our website at capra.med.umich.edu. There you'll find additional resources for conducting dementia-related research, including programming script, finder files to identify cases in publicly available datasets, algorithms to identify cognitive impairment, links to other seminars, and information about our podcast, Minding Memory, hosted by Matt Davis and Donovan Most. In our podcast, you'll hear from leaders in the field as we discuss important topics related to dementia research. Podcast episodes are available on SoundCloud as well as Apple Podcasts. If you enjoyed this seminar, please consider subscribing to our YouTube channel or signing up to our email list through our website. Thanks for listening, and we'll see you in a future seminar.